This is the first video on thyroid gland pathology. I'm going to do a quick overview of some of the basic thyroid disorders and how they present, especially the polarity between hypo and hyperthyroidism. Then I'll go over some of the common thyroid assessment tests, what we do for history and physical exam, talk about some of the serological testing and imaging, and then specifically what's called the radionucleotide testing or RIAU testing. And then in subsequent videos, we'll look at hypo and hyperthyroidism. So patients with thyroid disease usually present with any of the following. So either thyroid enlargement, goiter. That's not going to be common in every thyroid disease, especially in the early stages. But especially later stage, like autoimmune thyroiditis and so forth, we have goiter. And it can be diffuse, or we can actually feel nodules in the thyroid. And that would be a nodular thyroid. Also symptoms, there could be symptoms of hypothyroidism or symptoms of hyper, and I'll review those here in just a second. And then we can have any of the complications of thyroid disease. So for example, with hyperthyroidism, the increased bone loss, increased incidence of arrhythmias, and the different aspects of hypo that we've already discussed in the physiology section. Many thyroid pathologies, though, are euthyroid. Euthyroid means that the thyroid gland, although there might be inflammation and damage occurring to the gland continues to secrete normal amounts of thyroid hormones. So our basic types of hypo or hyperthyroidism would be primary, and that's due to a problem in the gland itself. Secondary would be a problem of the pituitary with TSH secretion. Tertiary would be a problem of the hypothalamus and TRH secretion. And then there could be a peripheral disorder. These biomedically are not considered to be very common, but these would be problems, for example, of either poor conversion of T4 to T3 or problems of the thyroid hormone receptor. And I mentioned there are a number of polymorphisms that can contribute to those. Again, as I mentioned before, secondary and tertiary causes are often called central causes. So we talk about primary versus central and peripheral hypothyroidism. So in terms of hypothyroidism, there are many causes. We'll go over those later. The most common for the primary would be decreased iodine, and that's going to be worldwide the most common. But also in the US, the most common cause of hypothyroidism is autoimmune. Thyroiditis would be actual inflammation, often from infection. It could be bacterial, viral, fungal, and immunocompromised patients, etc. And then the primary causes of central hypothyroidism would be any tumor to the pituitary, any trauma, autoimmune disease, other infiltrative diseases like sarcoidosis and hemochromatosis and so forth. So we'll go over those in the hypothyroid section. But the presentation can be subtle, but usually there's some degree of fatigue, which is really a non-specific finding. A lot of conditions have fatigue. Bradycardia usually is typical, so slow heart rate under 60 or at least close to 60. Dyspnea on exertion, cold intolerance, muscle cramping, constipation, weight gain with decreased appetite, increased depression because of the loss of the LDL receptor or the lack of adequate expression of that receptor on the liver. We might have elevated cholesterol. That's also due to poor bile flow. Poor memory and concentration, hair loss, dry and cool skin. Carpal tunnel syndrome has been highly correlated with hypothyroidism. So these are the kind of things where a lot of musculoskeletal disorders, we think about them very physically, mechanically, but remember that these tissues need the right neuroendocrine support to properly regenerate. So thyroid is implicated in a lot of ligamentous problems, especially in carpal tunnel here. Sleep apnea, heavy menses in females is another fairly characteristic sign I've seen in hypothyroid patients. Myxedema, that would be from the mucin buildup in the skin. We already talked about with the skin pathologies, maybe around the face, the periorbital area as well. Increased carotenoids in the skin, causing it to yellow due to the poor conversion of beta carotenes into vitamin A. And then cardiac hypertrophy, maybe with coronary artery disease or leading into congestive heart failure. And then in infants and children, we have cretinism, is congenital, resulting from congenital hypothyroidism. The medical emergency related to hypothyroidism would be myxedema coma, which we rarely see now in the US because most people are screened and treated for hypothyroidism. But this is a very severe form of hypothyroidism with very low body temperature. There's no shivering, there's often confusion, mental cloudiness, severe bradycardia, and reduced respiratory rate. That really needs immediate correction to prevent it from becoming fatal. Hyperthyroidism will present clinically less commonly. There's a lot fewer cases of hyperthyroidism than hypo, especially in primary care settings. And the treatments and evaluation for hyperthyroidism are more involved and usually are going to require specialist care, maybe referrals to endocrinology and so forth. But again, in terms of primary hyperthyroidism, the causes would be autoimmune and thyroiditis. So autoimmune hyperthyroidism is called Graves' disease, versus again, autoimmune hypothyroidism would be Hashimoto's disease or Hashimoto's thyroiditis. Central causes would be tumors, again, trauma, autoimmune, etc., the same as we saw in hypothyroidism. Typically, like I mentioned in the previous videos, pituitary adenomas, which can cause secondary hyper or hypothyroidism, it's more typical for those adenomas to be hypersecreting if they're going to be functional. So that would be give rise to hyperthyroidism. The presentation, this would be causing the state of, any elevation of thyroid hormone would be thyroid toxicosis, and that's from excess thyroid hormone from any cause. That could be from endogenous oversecretion or taking too much thyroid, etc. And that would be hyperactivity, tachycardia, heat intolerance, fine tremor. That's one of the early presentations. You can actually accentuate that by having the patient hold their hands out, maybe even have them hold a piece of paper, and you can see if it is shaking. Diarrhea, weight loss, increased appetite, anxiety, and panic attacks. And in this case, because of increased LDL receptor expression and increased bile flow, there might be decreased cholesterol. Long term, again, this is more the concern. So we have the acute effects of kind of the sympathomimetic, kind of mimicking the sympathetic nervous system of thyroid. But long term, we're really concerned about the loss of bone, osteopenia, osteoporosis with hyperthyroidism, increased risk of cardiac arrhythmias like atrial fibrillation, exophthalmos. We'll talk about that. That doesn't happen in every case of, so that presents with the Graves' disease. So again, not everything is autoimmune in this case, but autoimmune hyperthyroidism, Graves' disease, about 30, maybe 40% of those patients can also develop exophthalmos. And I'll talk about that, but that's where it looks like the eyes, and they actually are literally being pushed forward. There's increased deposition of fat and scar tissue behind the eye, the orbits of the eye. And this can actually push the eyeball forward, and as a result, the eyelids don't fully close, and they don't provide the right lubrication to the sclera, and the sclera can become very dried and injured from that. And then pretibial myxedema could occur here, and that has sort of a reddish, kind of orangish appearance on the shins. So that would be with hyperthyroidism. The medical emergency here is thyroid storm, and that's a very severe form of hyperthyroidism with high temperature, confusion leading into psychosis, tachycardia, increased respiratory rate, and this has a very high mortality rate. Even with treatment, it's up to 50% in some patients. But a common cause of that would be overtaking thyroid medication, but again, any of the autoimmune or other causes of hyperthyroidism. So that's a little overview of the kind of presentation of hypo and hyperthyroidism. So in terms of thyroid assessment, let me just kind of go through all the different steps we do for assessment, and I'll talk with the individual thyroid disorders about kind of specific tests and values and so forth. But basically with assessment, we're going to gather in our history any symptoms of hypo or hyperthyroidism. We're going to look at a history of any autoimmune disease. So with autoimmune thyroiditis, there's going to be a higher incidence of other autoimmune disease like pernicious anemia, vitiligo, even type 1 diabetes, etc. Celiac disease, another big one that could be correlated, usually with the hypothyroidism. Evidence of ionizing radiation exposure, excess or deficient iodine ingestion. So if patients, we want to document how much iodine they're taking, if they're taking any supplements, any medications that contain iodine, like the amiodarone or lithium. Lithium doesn't contain iodine, but it can directly inhibit the thyroid as well. And then a family history of thyroid or autoimmune disease. So those would be some of the classic questions we would want to gather in the history. Physical exam, we'd want to observe the gland straight on, so from the front. So while you're interviewing the patient, you can kind of do this. And maybe have the patient swallow. That's going to move the thyroid gland up and down. We're going to look for bilateral symmetry. Look for the presence of any nodules or general thyroid enlargement. Again, in the large thyroid, a goiter can be diffusely enlarged, like in this picture down here. So this woman has very diffuse, so here's the thyroid gland, very diffuse enlargement all around here. And then in this patient down here, this looks like a single thyroid nodule that can be palpated. So those are the kind of things we'd want to first just look for. The next step would be to actually do the thyroid exam, and a good review of that is actually, you can go online and look at Stanford 25. They have videos on the top, what they consider to be 25 most important physical exams that physicians, anyone in a primary care kind of setting should know about. And they have one on the thyroid exam, so that may be good to look at that video. But we want to, again, look at the thyroid face on. We want to then palpate the gland, and there's a couple ways of doing that, but the typical position is from behind. Now, some patients do not feel comfortable with this, so it's very important to check in with the patient to see if, first of all, they allow you to do the exam, but also that this position is not going to be too uncomfortable for them. It's almost, they might feel like they're being choked. But you stand behind basically, and you want to kind of put your fingers along the midline, and then you want to kind of there feel the actual texture of the thyroid. The normal thyroid should be just barely palpable. It should have a smooth surface, kind of a soft, rubbery consistency. Each lobe should be about 2 centimeters vertically in height and about 1 centimeter horizontally. Again, any enlargement would be a goiter, and we want to differentiate, is this diffuse across the whole thyroid? Is it nodular? And also, is it painful or painless? Because most of the autoimmune thyroiditis, like Hashimoto's and Graves', is usually painless, but a thyroid infection is typically painful. Another helpful thing is to have the patient swallow while you're doing this, and that way the thyroid will kind of move up and down, and that makes feeling any potential nodules and whatnot more likely. Other aspects of the thyroid would be to, after you do the exam, would be to listen. So usually with the diaphragm of the stethoscope. And this is going to be more typical of more enlarged thyroids, goiters, would be to listen for bruits. Palpate the thyroid gland itself, checking for the thrill, that's the vibration, and that's due to compression of the thyroid arteries in an enlarged thyroid. Checking for the cervical lymph nodes, see if there's any enlargement there. Any evidence of tracheal deviation, so you can kind of feel down the trachea, see if it's midline. And then check for any jugular venous distension with large goiters. If they get really large, they can compress not just the arteries, but also the veins. So the jugular vein can be compressed, and that would lead to blood backing up, and that will cause JVD. And then another test, which again, you can look online. They actually have a couple videos on this I've seen posted on YouTube, would be Achilles reflex test. This is not recommended for screening for hypothyroidism, but it can be a very helpful test for assessing response to therapy. And that is basically, in hypothyroidism, you're going to have hyporeflexia. All your reflexes will be delayed. Well, if you check the Achilles tendon, that's usually the patient lying in a prone position on the table. You can, with the reflex hammer, tap the Achilles tendon, and if there's a delayed return of the foot, that could be indicative of hypothyroidism. So that would be one. Now, until about the 1950s, 60s, physicians used to use a couple of tests to assess for thyroid function before we had the current blood tests that we have now. But they used, for example, I mentioned the cholesterol levels. If they were elevated, that was for some an immediate indication that a person had hypothyroidism. But basal body temperature was frequently used as an assessment tool for thyroid. And so you'd put first thing in the morning before getting out of bed, usually using your axillary temperature. You'd put a digital thermometer in there. Before the 50s, you didn't have one, so you had the mercury thermometers, but you have to keep it in for up to 10 minutes. And then we would look at the body temperature. So a decreased basal temperature, and that could be axillary or oral. If it's less than 97.8 oral, that could suggest a weakness in the thyroid activity or the adrenal activity, especially with DHEA and androgens, the male hormones. So it's not specific for thyroid, but they could indicate low thyroid. And there's different times. It was recommended for menstruating women to take this on the second or third day of menses, so at the beginning of the menstrual cycle, because that way the other hormones, estrogen and progesterone, wouldn't interfere with the temperature. And it's highly variable, obviously, depending on many factors. So it's not thyroid specific or sensitive, and that's why the current guidelines really are suggesting this should not be used for screening for thyroid disorders. However, if a person is diagnosed with hypothyroidism, like the Achilles reflex test, it might be used to follow response to therapy. It's just not convenient for a lot of people to take their temperatures, every morning. They might forget before they got out of bed and those sort of things. But that used to be a very commonly prescribed test before we really had the current line of blood tests that we use now. So the serological tests have really replaced basal body temperature as our primary screening, but also kind of assessment and tracking method for thyroid disease. The guidelines are somewhat disputed, especially in the more functional community, in terms of what are the optimal levels for our different tests. So I'm going to base the data here as a starting point on the NHANES data. This is the National Health Registry, National Health Nutrition Study. We looked at, I think it was a very, very large patient cohort, gathering all the information about their nutritional intake, their thyroid status, etc. And this data was looked at by several organizations, including the American Association of Clinical Endocrinologists, the AACE, and the American Thyroid Association. So these are really considered to be, in the US, the guideline committees for where we look to find what we consider to be normal lab values and so forth. And both of them have put together a joint kind of publication on the assessment of hypo and hyper and thyroid nodules and so forth. And they've done a very exhaustive literature search on, okay, so what is the optimal levels? What are the optimal goals for treatment in terms of levels and so forth? And they have, I think, done a very good job of answering a lot of the questions people have around this. And they present all the literature that they've used to gather that data. Their guidelines came out in 2012, so I would expect that this would undergo another sort of assessment here, probably in the next couple of years, if not sooner. So we might see new guidelines come out. But according to those guidelines, the primary assessment tool that we use for assessing thyroid would be TSH, the thyroid stimulating hormone. So it's the most reliable, accurate marker and most sensitive marker for thyroid function. Again, there's some controversy. I'll get into that maybe later in the clinical section about, could it be that the brain, the deiodinases in the brain are converting T4 to T3 adequately, so that way the brain actually perceives you have adequate thyroid levels in the blood. But it could be that your peripheral tissues, the deiodinases, are not functioning optimally there, and you could actually be essentially starving of thyroid in your skeletal muscles, but the brain is not perceiving that. So the TSH level, again, reflects really what the hypothalamus and pituitary are sensing, and may not necessarily correlate with what's going on in the rest of the body. So there is some controversy about that, but we pretty much take this as our primary test today. The levels stay stable in life. They increase a little bit as we age. If a patient is taking thyroid, levothyroxine T4, the TSH, if there's any variation in the TSH, we consider that to be mostly due to non-adherence to the medication. Again, there is a TSH circadian rhythm. It's highest in the early morning hours, and then it decreases after noon. So if like from noon to 3-4 p.m., it's at its lowest levels. The exact range remains controversial. So the current AACE and ATA guidelines are for non-pregnant adults, the ideal TSH range is 0.4 to 4.2 milliunits per liter. So that's the typical recommendations there. Now, if you look at a lot of labs, they slightly deviate from this, and that's based on their own pools of data, but these are the current basic guideline ranges. Just for simplicity's sake, I usually look at, around 0.4 or 0.5 to 4. So 0.5 to 4 kind of gives us our basic range for normal TSH. This is going to change in pregnancy. In the first trimester of pregnancy, the ideal ranges are 0.4 to as low as 2. And in second trimester, it goes up, the high end goes up to 3, and then 3.5. And then after pregnancy, again, back up to 4.2. So that is the basic guidelines. Now there's controversy. There was a survey called the Wickham Survey done in England from 1972 to 1992. And the data from that suggests that hypothyroidism symptoms begin with the TSH as low as 2. So anything above 2, some people suggest is hypothyroid. So there's this, I think, if we say, let's take 4 is the upper end of our AACE, ATA guideline range, and then 2 is maybe the other range. We have this question mark between 2 to 4. Is a person considered hypothyroid when their TSH is in that range? We definitely know above 4 they're hypothyroid. From 0.4 to 2, we know they're euthyroid or normal. Under 0.4, we might be hyperthyroid. Again, I'm talking about primary thyroid disorders here. The big question then would be between 2 and 4, would a patient in that range need medication? And that actually has been studied where we've given patients in that range thyroid medication and corrected them to under 2, and it didn't result in any improvement in any of the other measures that were looked at in those studies. So in terms of quality of life measures or any of the thyroid symptoms, didn't really seem to improve, especially in that range. Now, some of the older guidelines went up to a TSH of 10, and they said, really, you're fine until you get over 10, and then you just think about medication. So there used to be a question between 4 and 10, should we give thyroid there? Now, pretty much that's been, we pretty much see the thyroid supplementation for a lot of people in the primary care setting begins after 4. Now, we'll talk about all the approach to autoimmune hypothyroidism, Hashimoto's, because it's a lot more than just correcting thyroid. You have to also address the autoimmune component, which is not typically done in the biomedical settings. So they're pretty much kind of in the biomedical approach, we just correct thyroid, and we're using the TSH range to help guide the therapy. Increases in TSH would indicate, like I just mentioned, primary hypothyroidism. It could also indicate less commonly secondary or tertiary hyperthyroidism. So that basically would be if your pituitary is churning out too much TSH or the TRH increases from the hypothalamus, you would have secondary or tertiary hyperthyroidism or primary hypothyroidism. A decreased TSH could be a primary hyperthyroidism or a secondary tertiary hypothyroidism. So that's why we can actually predict a lot from TSH measurements, as well as adding in the next one, which would be a measurement of free T4. Okay, so that's TSH. Free T4 is not recommended as a screening test, but if your TSH falls outside the normal ranges, then it's suggested you get a free T4 to help further assess this. Now, some physicians just from the very beginning get a TSH, a free T4, and a free T3. And interestingly, according to the AACE and ATA, they suggest don't do that, because if you actually did that on every patient and we calculate what the cost of the medical system that would be, it's enormous, and it really would not pick up a lot of thyroid disorders. So they recommend it's best to screen first with TSH, then come back for a free T4 if you need to after that. But especially in the more functional circles, a lot of patients have already been through this testing, and so we're just going to jump straight to maybe also gathering a free T4. So this is going to be the most important indicator of actual thyroid levels in the blood. Rarely the total T4 is measured. Remember, total T4 is going to be your bound T4. I'll abbreviate that BT4, and that's the T4 that's bound to carrier proteins plus the free T4. That's total T4. The free T4 is the only one that's available to the tissues. You can measure this But again, this is going to vary depending on the level of your binding globulin. So like the thyroid binding globulin, if that level goes up, your total T4 will go up. So it's like, oh, that's good, your thyroid's going up. But all of that thyroid is going to be bound to protein. It's going to be unavailable freely to the tissues. So we have to, in addition to total T4, measure the level of the thyroid binding globulin and do some calculations to figure out your free levels. Now we just do a direct assay on the free T4. And we combine this with the TSH test, and that gives us a lot of good information. So as I said, the total levels are going to be affected by thyroid binding globulin levels. Remember, estrogen, high estrogen states like pregnancy, taking oral contraceptives will increase the thyroid binding globulin, or the T4 binding globulin, and that will give us a falsely elevated or an elevated total T4, but your free T4 might be low in those cases. And similarly, in high androgen states and taking steroids, we might see a low TBG, and that would give us a different value there. So that's why we usually just go straight ahead and measure the free T4 now. Guidelines suggest the ideal levels between 0.8 and 1.8 nanograms per deciliter. Notice nanogram, this is tiny, so 10 to the minus ninth. That is, if you look at the homeopathic literature, a 9x homeopathic dilution. So pretty amazing at these tiny levels of hormones, how much of a profound effect they can have on physiology. So free T4 is going to be decreased in hypothyroidism, it's going to be increased in hyper. If you add the TSH into that, we can start to differentiate all these different thyroid disorders from one another. Now, importantly, T4 is unfortunately not a useful test when a patient's already on levo. Patients will have a higher T4 several hours after taking that, and then low or to normal ranges after. And then they're going to have generally low normal or low T3 the normal individuals. So the guidelines suggest we should not be doing free T4s in patients who are already on levo because of the kind of skewing of the test that way. And that's why we usually use the TSH as our primary measurement. Free T3 is, again, going to be measured of your actual active thyroid hormone. But again, what we really are interested in is the T3 inside of cells, and we cannot directly measure that. So this is what has leaked out of the cells and also maybe the product of liver conversion. So the guidelines actually do not measure free T3 as a way of assessing thyroid function, except in hyperthyroidism. Here too, there's actually a total T3, but that's again rarely measured. So free T3 can be helpful in hyperthyroidism, and the kind of range in non-pregnant adults would be 2.3 to 4.2 picograms per milliliter. And it's going to be increased in hyperthyroidism. It's the last hormone to become abnormal in hypothyroidism. And the other thing to think about with free T3 is the laboratory assay. There's a lot of things that can skew the results on that. So it's not considered to be a particularly accurate test. And so this really is not currently recommended by the guidelines as a standard screening tool or assessment tool for hypothyroidism. Again, there's some role in hyper. So that's deviating against the practice I see in a lot of functional medicine practices or naturopathic practices. They often are all, people are getting their T3s measured, free T3s measured all the time. But keep that in mind that there's a lot of controversy about that. The other big tests that we use, so those would all be thyroid function tests. We can also measure thyroid autoantibodies. And the big ones would be anti-thyroid globulin, so that's TG antibody, and then anti-peroxidase. Remember, tissue peroxidase, TPO, is the oxidizing enzyme inside the thyroid, and that is going to convert the iodide ion into iodine so that it can be organified and attached to the thyroid globulin. Well, in autoimmune thyroid disease, the immune system makes antibodies against that, so that can be measured as well. And then there are TSH receptor antibodies. Again, I said earlier they can be stimulating or blocking. The ones we're most interested in are the thyroid stimulating antibodies that we find in hyperthyroidism, autoimmune hyper. So that would be assessment, a workup for autoimmune hyperthyroidism. So the anti-TG and anti-TPO is going to be increased primarily in Hashimoto's. In fact, the TPO is probably going to be the most accurate of the two. And then the thyroid stimulating antibody, sometimes they're called the LATs, that's going to be increased in Graves' disease and hyperthyroidism. The antibody in that case binds to the TSH receptor and stimulates it. Now, the guidelines suggest that really you just need a yes or no answer. If the antibodies are elevated, that confirms a diagnosis of autoimmune thyroiditis. There's no need to track those antibodies because they do not track well with the level of inflammation that's happening in the thyroid gland. As we'll see with Hashimoto's, the antibody production is actually secondary to the main immune problem, which is the what are called the CD8, the cytotoxic T cells. Those are the cells that are actually causing the damage to the thyroid. And the antibodies are kind of a byproduct of the B cells being activated, and they secrete antibodies. So they're not really the problem, and nor do they necessarily correlate with the level of inflammation and damage in the thyroid. So the guidelines say really just track the thyroid. That's most important. Maybe use the antibody test to just confirm from the beginning that it is autoimmune thyroid disease. Now that said, because in the United States iodine deficiency causes of hypothyroidism are very rare, most physicians will not even measure these. They'll just automatically assume a patient with all the lab markers indicating hypothyroidism, primary hypothyroidism, has Hashimoto's, and is just kind of treated with thyroid hormone. But I do find I've had several patients where it was actually helpful to do the testing to show that actually it's not autoimmune. The issue is about 10%, I think the estimate is, on Hashimoto's patients, the antibodies are normal. So that also confuses the picture, in that at the early stages especially, we might not see the antibody elevation yet. We also have the opposite picture where for many years people have elevated antibodies and they have normal thyroid function, they're euthyroid. But in those cases, about 5%, maybe up to 10% per year convert to hypothyroidism. And so that's another issue we have. So it's a little confusing with the antibody markers, but we do use them as a general yes or no answer as to whether or not a person has an autoimmune thyroid disorder versus another cause of hypo, or in some cases hyperthyroidism. I have seen people track these over time to say, oh, you're getting better because your antibodies are going down. Again, the data suggests you can't do that. Antibodies might go down, but the inflammation that might be occurring from those other immune cells, the CD8 cells, continues. And there's more continued fibrosis and whatnot occurring in the thyroid. So be careful about that trap of doing serial antibody testing. Okay, so those are the basic serology tests we use for assessing thyroid. I'll just mention a couple other tests here, other thyroid function tests. These are not as commonly used. We've already talked about reverse T3. Remember that reverse T3 is kind of the disposal form of thyroid. Once the body is finished with thyroid hormone T4 or T3, it's converted to reverse T3. This cannot bind to the thyroid receptor, and then it can be easily disposed of. So we see an increase of reverse T3 whenever that type 3 deiodinase is activated, and that's going to happen in severe critical illness as well as high cortisol states. Usually it's because of the cortisol and critical illness that this happens, but also because of other mechanisms. The body basically downregulates metabolism, so to work on other, keep the body alive. So the metabolic responses go down and your reverse T3 goes up. The typical range is anywhere between 90 and 350 picograms per milliliter. Remember, the half-life is very short, like 20 minutes, 30 minutes, and it's going to fluctuate wildly throughout the day. So this is not recommended by any of the guidelines as a useful test for routine measurement. In critical care patients, it could be helpful for detecting that non-thyroidal illness syndrome we talked about. But this really is not a good test for thyroid function directly. Now, where the kind of functional medicine community is using this is to look at, well, maybe this could be another indicator of high cortisol, is if you had high reverse T3. And that might very well be true, but there's really usually no need to do the reverse T3 if there's high cortisol, or more typically what we call HPA axis dysregulation. that's what you need to work with, not so much, the knowing about the reverse T3. Some circles, I've heard the term where reverse T3 actually binds to the thyroid receptor and blocks it from any further T4 or T3 stimulation, and I have not seen any evidence to support that claim. In fact, it's just that the reverse T3 doesn't. It just basically uses up your T4 and T3. It's all converted to reverse T3, and that can't bind to the receptor, and then it's washed out of the system. Again, there's a couple of papers written on looking at the role of the ratio between free T3 and reverse T3 to tell you a bit about how much active T3 is available to the tissue. So that could have some potential merit, but I don't think there's been any large-scale surveys looking at big population cohorts to see how accurate that ratio is. Rarely we do what's called the free thyroxine index, so that is going to be obtained by multiplying the total T4 by the T uptake, which is how much binding globulin there's present, and then the thyroid hormone uptake itself. This measures a measure of the unbound thyroid binding globulins, TBGs, thyroid binding globulins in the blood. We can say this is a measure of the unsaturated thyroid binding proteins. Typically, it's about 25 to 35%. If that increases, that means it's saturated with more thyroid hormone. If it's less, there's less thyroid hormone. These used to be kind of some of the main tests we had before we did the TSH, the free T4 and free T3, but now they're rarely used. So that's an overview of all the basic thyroid function tests in terms of serology. Lastly, I want to talk about thyroid imaging. So some of the basic tests we have are ultrasound. We can do high resolution of ultrasound on the thyroid. It measures the size of the gland, any nodules or whatnot that might be present, and then it can look at the nodules and see if they're solid or hollow. Hollow nodules are cysts, and the cysts are almost 100% benign, so we don't have to worry about those. The unfortunate thing about nodules is about 1%, or maybe a little bit more, turn out to be malignant. And so we need to actually go further, and I'll talk about a test here where we can actually do, with the ultrasound, a biopsy, where a biopsy needle is passed into the nodule, and that can be examined microscopically. The ultrasound can measure the borders of any nodules, and if the nodule is benign, it tends to be very smooth bordered. More potentially malignant nodules will have a rough border. And so it can help differentiate between benign and malignant nodules. And again, the fine needle aspiration biopsy can be used to go in with a needle. Usually they take several cores and out of a suspicious nodule and can analyze those. So that would be for thyroid nodules, or just assessing in goiters. We can use the ultrasound as well to see if there's any compression of the carotid arteries or the other thyroid arteries, as well as that recurrent laryngeal nerve compression. But probably the most useful test for hyperthyroidism, as well as differentiating between a nodule that is hypersecreting, which we call a hot nodule, versus one that's not hypersecreting, we call that a cold nodule, we can use what's called the radionucleotide imaging, or thyroid scintigraphy, the RAIU test. And this uses a radioactive form of iodine. It's iodine 123, has a short half-life, so it's not considered to be carcinogenic or anything like that. Technetium-99 is another contrast, or another radioactive isotope that can be used here. And basically, what's going to happen is this is injected intravenously, and then the thyroid will concentrate that iodine 123, and then we can use a special gamma camera to take pictures of the thyroid and see how the thyroid concentrated that isotope. So here are some pictures of different RAIU scans. So looking at normal kind of distribution, we can see on kind of an uptake. We actually get a measure called thyroid uptake, and that will actually show you how much of the tracer was taken up by the thyroid. Is it bilaterally distributed, or do we see it more distributed in a pocket, maybe suggesting a nodule that is taking up a lot of thyroid? And if you measure their blood tests and they're hyperthyroid, that means this is a hot nodule. It's hypersecreting. And the good thing about those is the hot nodules are almost never cancerous, so we don't have to really worry about those in terms of working them for cancer. You'd of course need to treat them for hyperthyroidism if that's an issue. But if the nodule does not take up the tracer, that's more consistent with what we call a cold nodule. And the problem there is, again, a certain proportion of those can turn out to be cancerous. So the RAIU scan can help us differentiate this. I'll say more about what actually we measure and what the kind of scoring system is when we look at hyperthyroid. If the entire gland takes up a lot of thyroid, of the tracer, and a person is hyperthyroid, doesn't look like there's any nodules, that's a pretty clear indicator of Graves' disease. So that would help us differentiate the different types of hyperthyroidism. Okay, so that's RAIU, and then we can use MRI and CT. That's going to be more helpful for getting if there's concern of any metastases in the form of Graves' disease, where we get the exophthalmos, the orbitopathy, where we get the fat deposition behind the eyes, and MRI could be helpful for assessing the severity of that as well. And then I mentioned the thyroid, the fine needle aspiration biopsy, using a 27 or 25 gauge needle, and that is going to, with an ultrasound guided, it's going to be guided into any suspicious nodules, be able to pull out a sample of the cells and examine those. So that is our major thyroid assessment imaging tests. So with the serology tests, with history and physical, that allows us now to pin down and narrow down different thyroid disorders. So in the coming videos, we'll look at goiter in general, but also hypothyroidism, hyper, we'll talk about thyroid nodules, and end with a discussion on thyroid cancer.